Outpatient orthopedic physical therapists need to take more blood pressure, and I'm going to tell you why. Let's start with a simple scenario, a patient that is very common within outpatient orthopedic physical therapy. It's a 50-year-old male experiencing left shoulder pain or discomfort. He has pain when he's lifting overhead. He's an electrician. He had a torn rotator cuff 4 years ago. The pain slash discomfort that he's feeling now is he's not really sure when it comes and goes, but it did onset roughly 3 weeks ago. You perform your upper quarter screen and you find no significant findings. You perform bilateral glenohumeral active range of motion and passive range of motion and find that the left side is more limited than the right side for both active range of motion and passive range of motion. You perform MMTs of both sides of the shoulder as well as parascapular muscles, and you find that the left side overall is weaker than the right side. You perform special tests and you find a positive NIRS and a positive Hawkins-Kennedy, but a negative ER lag and negative liftoff. You believe he falls under the ICF diagnosed category of shoulder pain with mobility deficit, with an ICD potentially being subacromial pain syndrome, also known as SAPS. Your rationale is that he's having limited range of motion. It's one-sided. He's 50 years old. He has an overhead occupation. There's no mechanism of injury to suggest it is anything ligamentous or muscular based. And you still have the positive NIRS and Hawkins-Kennedy, which suggests that you cannot rule out shoulder impingement as a possible diagnosis. Due to scheduling conflicts, and he has a busy day, you put him on a one-time per week plan of care with diversity of billing, including new step for warm-up, joint mobilizations for manual therapy, interventions that target increasing range of motion for therapeutic activity, as well as increasing muscle recruitment of the glenohumeral and parascapular muscles for neuromuscular reeducation. Upon his second visit, you place him on the new step for his warm-up to get therapeutic exercise. You go to your office to grab a quick bite because you want to work through your lunch because you've had a rough morning and you want to go home early today. But he starts to experience chest pain. He starts to experience a myocardial infarction. Here's what went wrong. Here's what the physical therapist that would have been treating this patient missed. He had a history of hypocholesteremia. He had a history of stage 2 hypertension, which we will discuss later. He had a history of smoking. The pain in his shoulder only onset when carrying tools and equipment up stairs and ladders, thus leading us to believe that it's more cardiovascular based, more than mechanical based. His right side was stronger than his left side because he's right arm dominant. And he was currently experiencing that left shoulder pain slash discomfort he was talking about while he was walking into the clinic today. Now, there's a lot that went wrong here in terms of subjective history and as well as the plan of care. But we're going to focus on the stage 2 hypertension and how his blood pressure could have been a major screening factor for determining his plan of care ahead. So, what is blood pressure? Blood pressure is the result of your cardiac output multiplied by your total peripheral resistance. Cardiac output is the amount of stroke volume you have multiplied by your heart rate. Your stroke volume is the amount of blood that is being pumped through your system out through the left ventricle with each contraction. So your blood pressure is the result of three things: your total peripheral resistance of your arteries, the amount of blood being pumped by your heart, as well as your heart rate. Your blood pressure is measured via baroreceptors. Baroreceptors are nerve endings that are stimulated by stretch. So as the pressure of the artery increases, it places a stretch on those nerve endings, thus sending signals to the brain that there is in need of correction of increasing the heart rate or decreasing the heart rate to control the pressure. These baroreceptors are located within your aortic arch, your carotid sinuses, as well as your heart within the atria and the ventricles. The aortic arch receptors communicate via the vagus nerve, cranial nerve 10, and your carotid sinus receptors communicate via cranial nerve 9, your glossopharyngeal nerve. They send signals to the autonomic nervous system via the nucleus tractus solitarius, which is housed in the medulla of the brainstem, thus proving that blood pressure is not just a heart issue, it is an entire body function issue as it communicates to the brain and the rest of the body. So, what is hypertension? Hypertension is simply just having high blood pressure. As you can see in the chart below, what normal is and what elevated classifies as. Hypertension starts as soon as blood pressure is equal to 130 for systolic or greater, or diastolic being 80 or greater. You can have stage 1, stage 2, as well as a hypertensive crisis. If there is anything that is important to take away from this video, it is that hypertension in itself is asymptomatic. Patients will oftentimes come in and talk about how they're feeling like their blood pressure is high because they have anxiety, they're feeling stressed, they didn't sleep well, they're sweaty, all kinds of different things that we hear from them. But truth be told, those are issues in and of themselves. That has nothing to do with their blood pressure because blood pressure is asymptomatic. Having hypertension is asymptomatic. They will not feel their symptoms. And that can sound like a good thing because if you're in a hypertensive crisis, you really should be seeking professional medical attention, but you can still carry on with your day. You can still walk your dog, you can still play with your kids, you can still go to work. But ultimately, it's a very dangerous thing because, like I said, being in a hypertensive crisis means that you should be seeking professional medical management to reduce your blood pressure and control it better. So that way you don't result in the case that we just had, where then you go into a myocardial infarction or anything else that can potentially lead to catastrophic changes in your quality of life. So, some statistics here. Hypertension is a modifiable risk factor of cardiovascular disease. Cardiovascular disease is the #1 leading cause of mortality in both men and women across the United States and the world. I'll touch on the modifiable risk factor in a little bit, but hypertension is present in 34% of the US population, and less than 50% with that diagnosis are effectively controlling their diagnosis. And it's easy for physical therapists to say, like, this is a patient that we're not going to see because only 34% of the US population has it. But it is a very common risk factor seen in outpatient orthopedic physical therapists. It is as common, if not more common, than seeing physical inactivity in patients, obesity, diabetes mellitus, and smoking, all of which are quite common and on a very typical everyday caseload. Studies have shown that over 75% of outpatient orthopedic physical therapists reported that more than a quarter of their caseload includes patients with cardiovascular disease or risk of. More than 50% reported that over half of their caseload includes these types of patients. 69% of these physical therapists encounter a new patient with cardiovascular disease or at risk of 2 times per week. On a typical 5-day work week, that is 40% of the time. 30% of outpatient orthopedic physical therapists encounter a new patient with cardiovascular disease daily. And the most unfortunate statistic that I have here is that only 10 to 15% of outpatient orthopedic physical therapists report measuring blood pressure upon initial evaluations. Only 10 to 15% are successfully screening patients of having hypertension. Only 10 to 15% are effectively screening for a modifiable risk factor for the leading cause of mortality of men and women across the US and worldwide. So, my call to action to you, fellow physical therapists or those striving to be. Hypertension leads to changes within the elastance within the arteries, thus creating vascular endothelium dysfunction. Vascular endothelium dysfunction, the endothelium is what surrounds the artery and allows it to function and take on that stretch due to the increase in pressure that sends the signal to the baroreceptors. Hypertension damages that endothelium and causing dysfunction, leading to things such as stroke, cerebral artery disease, coronary artery disease, myocardial infarctions, blood clots, or hypertrophic cardiomyopathy, and many other diagnoses to include. As I touched on earlier, it is a modifiable risk factor. Modifiable risk factor meaning that this can be controlled via lifestyle changes with dietary changes. It can be controlled via pharmaceutical intervention or even physical therapy to increase physical activity and thus strengthen the heart in order to handle changes in blood pressure. Only 10 to 15% of outpatient physical therapists report screening blood pressure upon initial evaluation. If we see a 10% increase in effective hypertension treatment, we as physical therapists can prevent up to 14,000 deaths per year in adults for cardiovascular disease. The number one leading cause of death in both men and women across the United States and worldwide. If there's only a 10% increase in effective hypertension treatment, which starts with simply taking blood pressure, it starts with simply screening blood pressure upon initial evaluation, we can see up to 14,000 deaths per year in adults being prevented for cardiovascular disease. Thank you.